Right.
You probably remember me from last time if we have not met in person. I was saying to Andrea that I think my plan is to just kind of touch on some high level things to that you might want to know about, and then focus our time on making sure that the provider relief reporting stuff, you guys are comfortable with that. Maybe share a couple of tips and tricks. I don't know how many of you were able to be on the webinar we had on Tuesday. I will note that the recording of that webinar, including the 45 minutes of Q&A, are all going to be on the LeadingAge Learning Hub starting next week. So if you missed it, you'll be able to access that information. So I just wanted to highlight a couple of things. I think the last time we talked, I noted that there were some proposed skilled nursing facility prospective payment rules that were out. It's looking like those are going to be finalized any day now. And I note that because next week, August 5th at 2 o'clock in the afternoon, CMS is hosting their kind of long-term care SNF open door forum, and this is on the agenda. So final PPS rules are coming, and just to refresh your memory, they were proposing some adjustments to PDPM, some parity adjustments because the expenditures were kind of skewed, and this has to be budget neutral. Obviously, in our opinion, everything was skewed because of COVID, but we'll see where they landed on that. And it also included some language making some adjustments to value-based payment and quality reporting as well. So on the quality reporting front, I wanted to give you a heads up in case you have not seen this yet. Hopefully you haven't seen one because you don't want to see a quality reporting non-compliance letter. So quality reporting program, if you were considered non-compliant, it affects your fee-for-service rates. It reduces them by 2% for an entire fiscal year, and that would start October 1. For those organizations that received a non-compliance letter, and this would be in the QIES system, the Casper folders, if you received one, you might have received it by mail, but it would also be in your Casper folder if one exists. If you received one, you have until August 13th to kind of request reconsideration. Typically, the only reason you would request reconsideration is if you believed that non-compliance was actually an error and that you did submit sufficient documentation for them to complete to calculate the quality measures for the program. There is one other reason to request reconsideration, and that is because of kind of extraordinary circumstances. Everybody kind of got a pass for about 6 months of reporting. So this report is only covering a 6-month span of time. For some people, that's going to be problematic. I'm hearing dribs and drabs from people that they're getting non-compliance letters that didn't previously receive them. So just wanted to give people a heads up. There might be an opportunity to say, you know, we deserve a special exception beyond that for 6 months of 2020 because COVID impacted you a particular way or was particularly harsh in your organization or something like that. And so that might be a case, but any requests for reconsideration have to be submitted by August 13th. So I just wanted to give you a heads up. I know a couple of organizations around the country have been surprised by receiving these letters. So the other thing, did anybody get paycheck protection loans that have not yet been forgiven? Or is everybody good?
I did.
Okay, so Small Business Association is launching, I think starting next week, expected to go live August 4th. Yep, next week, a new online loan forgiveness platform where, and it all depends on how much you got. So if you got less than $150,000, which is about 90% of the applicants or the recipients, you'll be able to go through this platform instead of going through your bank to expedite that forgiveness process. They're trying to get everybody kind of sorted by the fall. And so there's going to be some more information coming out on that. So if you have less than 150,000 in PPP and it hasn't yet been forgiven yet, you'll want to pay attention because we'll be sharing more information on that as it becomes available. let's see. Just wanted to give you a quick note on you may have heard that a bipartisan agreement was reached in Congress yesterday, and that the Senate voted related to an infrastructure agreement. So what they've agreed to so far is really not our portion of what's being called infrastructure, but it was $550 billion that they've agreed to. And the only thing that's happened so far is that the Senate has agreed to kind of continue this conversation and move that through the process. We only have really high level details, and I'd say the only thing in this particular bill that will be moving that might be of interest to anybody, well, outside of generally, it's primarily roads, bridges, that type of thing, but the one item that might impact more rural areas is the funding for not broadband, but kind of widespread internet access. So I'm trying to remember, it's $50 or $60 billion for that. So that would be one area of interest. What's important to know is that the agreement is supposed to be tied to also passing a reconciliation package. And that's where anything referred to as kind of the care economy, or our items like the $400 billion for home and community-based services, potentially some workforce dollars for nursing homes, and expanding Medicare coverage to include vision, hearing, and dental, that will be in that reconciliation bill. So these two run separately, get voted on separately, but the agreement is supposed to tie those two pieces together. So this was as of last night. Everything could change again, but just wanted to give you a heads up that that's where things are moving. And if you've heard what's going on in Congress, that's kind of where things stand. Does that make sense? As much as anything in Congress makes sense. So I just thought I'd give you a heads up on that, because I know we're all kind of keeping track of where the money is going. So I thought I'd focus the rest of my remarks on provider relief. And I don't know if it's easier just to open things up to questions, or if you want me to just kind of provide an overview of some things you should be thinking about, or some common questions that I know have sort of repeatedly come up as people are trying to sort this out. Maybe do a few minutes overview and then we can go from there. Okay. I know it's one of those, you don't know what you don't know. So the good news is, I think the guidance that came out, which for all intents and purposes feels finally like the final guidance on how we report on provider relief funds, came out on June 11th. On July 1st, the reporting portal opened, and as part of that, some additional resources, documents, webinars, and sessions and recordings have all been made available. As we've sifted through, and I must admit, I still have a few more to get through because there's a lot of things out there. I found that between the guidance itself, what information is available on what has to be reported, the supporting worksheets that you can work through work through all the data elements you're going to have to enter up front, so you have it all ready when you go to report. Pretty clear. Up until this point, every time we got reporting guidance, we just had 1,000 questions about how it was really going to work. And now I feel like it's much more straightforward. There's still a few, I'd say, nits and gnats or questions that we still have, and I'll touch on at least one of those here. So I like to remind folks that the purpose of this reporting is basically to say, this is how I spent my provider relief funds that I received. And they're expecting you to do that over the course of, there's 4 separate reporting periods, and you can't do this all at once for all of your payments received. So this first reporting period is open right now, and you have to submit by September 30th. If this is only for payments that were received between April 10th and June 30th of 2020. So what that translates to is what we originally called tranche 1 and tranche 2. So if you were a Medicare provider, you got funds in April on the 10th and 24th of April 2020. It'll also include the targeted SNF distribution that was received, I believe it was May 22nd of 2020. A few people, and very, very few people, may have received some phase 2 funds during that time period. So if that applied to you, you got your application in early and got them by the end of June, you may have to report on those as well. So what you're reporting on is just how you use that bucket of provider relief funds. Now, what gets confusing is the April 10th to June 30th, 2020 timeframe, but the period for which those funds are considered available to you is from January 1st of 2020 through June 30th of 2021. So basically those funds, you could use for any expenses or lost revenues that incurred during that broader time span. So for that reason, you will also, when you report, be reporting on other assistance you received during that broader time span, your expenses related to COVID during that broader time span, and your lost revenues related to COVID during that broader time span. So that's where people get confused sometimes, because there's the provider relief kind of bucket time frame, and then there's sort of the broader time frame. And I think the good part about all of this is that they finally said, oh yeah, maybe you would want to be able to use that money over a longer period of time. So it's just that first round kind of set of funds from April to June of last year that had to be spent by June 30th of this year. So just keep that in mind. The other thing to know is that each of these reporting periods essentially kind of builds on itself, because every reporting period you will report expenses, and in this case, really just the new stuff that you hadn't reported yet, from January 1 through the next kind of deadline to use funds. So by the time you get to the fourth reporting period, if it applies, you'll have covered the full range, the full time frame. The benefit of that is, if, let's say you only got $100,000 in this first payment received period of provider relief, but you had $500,000, and I know I'm going light on these numbers, $100,000 received, but maybe $500,000 in expenses and lost revenues over that time. So you had $400,000 more than you got money for. Those expenses and lost revenues carry forward to the next payment received period. So the next bucket of provider relief funds, you can apply anything that didn't get reimbursed yet. So that part goes forward. If, however, over the course of, for this first reporting period, you did not use all of your provider relief for expenses and lost revenues between January 1 of 2020 and June 30th of this year, that difference of what you didn't spend would have to go back. Everybody tracking with me? Okay. I know, it's like follow the bouncing ball, because there's so many dates and numbers. So that's one thing to keep track of. The other thing I wanted to note that's been confusing for folks is there are two types of distributions that you would have received through provider relief. There are general distributions and targeted distributions. I will say that for every type of distribution except nursing home infection control distributions and incentive payments, every other general distribution and targeted distribution can be used for eligible COVID expenses and eligible COVID lost revenues. The nursing home infection control dollars, whether they were the distribution you received in August of 2020, or they were incentive payments that you received between November 2020 and February 2021, those dollars can only be used for infection control expenses. Now, the key thing you can easily go back and look at the definition of infection control expenses. It's in the terms and conditions related to those dollars. So if you got those dollars, you had to sign a test to terms and conditions. So it includes things you would expect, like testing and PPE and things like that, but it also includes staffing costs. And it's not just staffing, hiring staff, but also retaining staff. It includes some technology dollars. So anything to help residents, continue their contact with family and that kind of thing. Or, technology, if you had to support, upgrade your system to support more technology use and Wi-Fi in your building because of COVID, those things would be captured in that infection control expense. So it's a little bit broader than just infection control, but it's sort of related. But those dollars, no lost revenues can be applied to those dollars. Now, you don't have to worry about the nursing home infection control dollars right now, because you won't report on those until the next reporting period, which starts in January of 2021. So I'm going to pause there for a sec, take a breath, see if anybody's got any questions so far. Okay. So the other thing, we talked about a lot of things on the webinar yesterday, and I felt like it was really helpful to hear CLA's take on expenses and lost revenues. On the expense side, the way that their simplification was, if it was something that you wouldn't have spent money on before, but you did because of COVID, that's probably an expense that you can report here. So not kind of everyday expenses, but things that kind of went over and above. Because the terms and conditions in general related to expenses say it has to be to prevent, prepare for, or respond to COVID. So, you know, think about your expenses in that way. The other thing to keep in mind related to expenses, of course, is that you may have received other assistance along the way. If you got CARES Act dollars through your state, if you got a FEMA grant to pay for PPE, and the PPP loans themselves all go into this category of other assistance received. On the good news on other assistance received is, while you have to report it, it doesn't work against you in your lost revenue calculations. But from an expense perspective, you need to apply expenses first to each of those things. So COVID expenses that you got, if you can use any of those other assistance, coronavirus kind of assistance to cover those expenses, you have to do that first. And then if there's anything else that remains, then you could use provider relief funds for that. So at the end of the day, provider relief funds are sort of the payer of last resort. So first look to other sources that you got to cover those things. If they don't cover those things, then either the difference of what wasn't covered or the expense in total that wasn't covered can be covered by provider relief. But again, you have to report on that other assistance, but it's not going to factor into the calculation of lost revenue, which is a huge thing. A lot of aspects of these final regulations, I feel like they heard a lot of our complaints and concerns. And I think for providers in general, they've worked out to our advantage, which leads me to the lost revenue discussion. So there are 3 different ways to report lost revenue. You can do that comparison of actuals, year over year actuals, 2019 to 2020, 2019 to 2021, or you can compare budgeted to actual, but that option is really limited because your budget had to have been approved by March 27th of 2020. And you'll have to certify that either the board approved it or it was signed off by somebody. But your CFO or somebody else with that type of title will have to attest to that. So that makes that option fairly limited, and it's really confusing because what happens for 2021? You know, you probably didn't have your 2021 budget signed off on by March 27th of 2020. And if you did, it may have accounted for COVID by then. And so it might not be the comparison you want. So most folks are feeling like that option is probably not going to be the best bet for everybody. But you know, you want to think through each of these options and figure out which one's best for you. The third option is much more flexible in the sense that it allows you to offer your own methodology for how you're calculating lost revenues. And you'll want to be consistent in the application of that. But the downside of this one is that HHS has basically said, you know, you're going to be at a potentially higher risk for audit if you go this route. But it's sort of a good news, bad news, because if they look at the methodology that you propose and the narrative for how you did it and everything, and they don't agree that they think it's a reasonable way to calculate lost revenues, they're going to notify you of that and give you 30 days to go back and use either option 1 or 2, the actuals or the budgeted. So it's sort of, you can test it. For me, I think there's a couple of reasons why, a number of reasons why this one might be something folks want to look at. One is if your fiscal year is not a calendar fiscal year. So if you made it to June 30, 2020, and that's your end of your fiscal year, you might have had some pretty big losses by then that you would want to account for, and would have used provider relief funds to kind of backfill if you had them by then. So you might want to use, look at those calculations in a different way. Nonetheless, you're going to be reporting your lost revenues over by quarter over from January 1 for this first reporting period through June 30th of 2021. But there's a variety, the other reason one might use this alternate method is, for example, I know some folks, maybe they brought on a new building, a new assisted living building in February of 2020, not knowing COVID was just around the corner, and you didn't fill up as fast as you would have, or you sold a business during that time. So your 2019 budget and your 2020 budget just wouldn't look the same. It wouldn't really be an apples to apples comparison. Some people are also asking the question, and I don't know if I know the answer to this one, but you may have had a lower occupancy or fewer patient days in your skilled facility, but your PDPM rates were better. So the revenue side kind of was higher, but your number of patient days was lower. So, in a normal year, you would have had 100 patient days, let's say, instead of 60. Can you actually capture that? And that one I actually don't know the answer to, but that would be a good discussion to have with your accountant or auditor. Just another way to think about that. The other good thing that came out of the requirements and the additional resources that HHS has provided is, like I said, you're going to report lost revenues on a quarterly basis. So at one point they had talked about annualizing this. And it's possible that some folks over the course of 12 months didn't actually show a loss. What they're allowing you to do now by reporting it by quarter is they're saying that each one of those quarters is its own, is a contained standalone calculation. So in quarters where you do not show a loss, if that happened, if you came out even or even came out ahead, it's not going to be netted against the loss. That in those quarters, you'll just report a 0. So what'll happen is after you've reported all the quarters, essentially you're adding the form in the portal will add up all of the quarters where there were losses and give you a total loss number. So that's a huge advantage. If you had quarters where maybe things kind of stabilized and didn't look so bad, that's not going to work against you. It basically says you could use and backfill those losses with provider relief. So that's a huge difference from earlier guidance around this. Couple of things I wanted to note for life plan communities in particular. There's been a long-standing question about whether entrance fees can be included in the calculation of lost revenues. And what we're seeing from the frequently asked questions from HHS is that they're only going to permit the amortization of deferred entrance fees and not the cash proceeds. So that's I think not good news for folks that have been struggling with that. The other thing where we have to get a little additional clarification is one of the, essentially what you're reporting for lost revenues is you're showing your patient, what they call patient care revenue. Now for a life plan community or CCRC, typically that would include your SNF, your AL, your IL, and if you have home care or home health or something like that, it would include that as well. Pretty, typically pretty clear that your home care, home health revenue would be part of that. Your SNF would be part of that. They've made it clear that assisted living is part of that. But the latest definition that's in the reporting users guide does not mention independent living. And I think it usually has more to do with the fact that they don't know how we operate. They just don't, they're trying to cover a lot of healthcare providers with this information. So I want to get further clarification on it, but in general, I'm of the belief that the independent living revenues will be included, and I'll tell you why. So for anybody that applied for phase 2 or phase 3 provider relief funds, in the application process, we got it made very clear what could be included and not included in that patient care revenue calculation. And they told us as part of the FEQs at that time that independent living revenue, all of that, if it's under the same TIN, is to be included. So because you reported that as part of your application, and that's the data that they use to determine your provider relief payment, we have reason to believe then that it would follow that when you're reporting losses, that it would be the entirety. But I'm gonna get that submitted to HHS and just see if we can get a clear answer to that, just to make sure. Let's see if there was anything else I was going to touch on. I think I'm going to pause at this point. I'm sure we could talk about 1,000 different things, but see what questions you guys might have. I'm curious if anybody has started down this path, or that is one of the benefits, is you can go into the reporting portal and put in a little bit of data and it'll save and you can come back later. Yeah, huge advantage over application processes and other registrations.
We started it, we went in just to browse around and we wanted to make sure that we had all the information ready that was required. So we've got it partially saved with a few things.
Nice.
Yeah.
Now, was it, I'm just curious, because one of the things you're going to want to do is, and I don't know how many of you have multiple TINs or subsidiaries that have their own TINs or anything like that. You're going to want to make sure that all the folks that you're reporting on or that are part of your organization, that you've got to get those TINs entered, those tax ID numbers entered. And one of the benefits of that, so we asked for this repeatedly, we're like, hey, are you going to be able to give providers a report of what payments we allegedly received and when we received them? Because I don't know when to report, because I don't know what I got. And what happens in the portal when you put in all of that TIN information is it will give you a report of what they have funding wise related to those TINs. So you know, you're going to want to do the work up front to see, you know, what you think you have and what you saw in your bank account, and make sure that it's kind of matching up with what HHS has. But the nice part is you kind of have that confirmation and it tells you what you're reporting on, which is my other little tidbit, because it gets confusing because of all these different timeframes. If the portal shows you certain quarters, you're going to want to submit the data for those quarters. And if there's nothing to report, you just put 0. But it is they're only going to show you the quarters that you have to report data on. So don't ever limit yourself and say, oh, well, this is for provider relief funds between April and June, so I only have to report other assistance for those months. That's not how this works. If they ask for it, that's what they want. So hopefully that clears up a little bit of confusion, because I know all these moving timeframes are tough to track. Other questions, or anybody else who's gone in, what your experience has been?
Hi, this is Bill Ginter. I haven't populated anything in there yet, but I have a question about the infection control measurement. I know that that's not all that well defined yet, but is your expectation that the infection control cost measurements will also include all of the service lines under a TIN, or if those will be SNF only?
Well, so it's an interesting question, because originally I would have said, when those payments first came out, I would have said essentially the SNF had to use those dollars. But then they changed the language along the way and allowed, especially like parent organizations, to transfer dollars around within their organization as long as they were still healthcare providers that were preventing, and responding to COVID. So under that, I would argue that you should be able to use it for your assisted living expenses as well, and maybe testing more broadly. So if you're testing your IL residents or other folks, that it should apply more broadly.
Okay.
I know it's confusing, because the nursing home's the one that got the money, and on the incentive payments was the one that performed to get the money, but it's sort of a good news, bad news thing. I was worried where there were hospital districts that control SNFs, that they might just suck all that money up and the SNF might never get it. But I'm a little overprotective.
Anybody have any other questions of Nicole? On the broad range of areas that she's extremely knowledgeable of. There's our opportunity.
I was trying to think, have you guys all made it to the reporting and auditing page on the provider relief site? There are a ton of resources, and they've recorded their initial webinar on the reporting requirements. There's a short YouTube video on that's only like 5 minutes that walks you through the registration process. So if you haven't yet registered in the portal, it'll walk you through that. They've had 2, they call them technical assistance webinars, but they're sort of an office hours Q&A session. I haven't listened to those yet, but there was one July 14th and one July 20th, where they also answered a number of questions, and some of those answers may not yet have made it into the FAQs. So the guides on there I find incredibly helpful. There's user guides for the reporting portal itself, for the registration process. So if you stumble along the way, the nice part is you can just go to the section of that user guide that you need at that moment. And I feel like for the most part so far, it seems like they're pretty straightforward and clear. But if you guys have questions along the way that you just can't get the answer to, you know, certainly reach out, because that's what we're here for.
We're probably, it sounds like we may be in High Zell Gaston with Elam Park Baptist Home. We're probably in an unusual situation, I guess, because what you're saying is that including the revenues of the IL will help keep the funds. But it seems like for us, we actually did okay on the IL side. And so this would actually have a negative impact to us. I was totally focused on the nursing home side and all my reporting and everything. And now, especially if we have to include entrance fee amortization, which is non-cash, as we all know, revenue, that so I feel like I'm going to have to check with our auditors, accountants now, because I feel like I may be at risk of losing a lot of these funds we've received now. So I guess it's a good problem in one sense, but
Right.
certainly wasn't expecting that, because the nursing home side lost a huge amount of money.
Sure.
But now it's, if we're having to offset that with the IL side, I'm concerned that now we're not going to be able to keep those funds.
Right.
Any thoughts on that?
That, you know, it's a good question, because, you know, the whole point of provider relief was to help help fill those gaps. It wasn't to make, you know, they've said repeatedly they didn't want to make anybody profitable, but they also didn't want to leave you with a gaping hole. There was also no promise of fully reimbursing for you know, every lost expense, or every expense and every lost revenue. So I think I keep going back and forth, because there's a number of situations where it's a question of how you use the provider relief fund. So you know, I don't know. If it's all under the same tin, it's going to be hard to exclude those things out, because for the most part, they go back to the revenues for the tin. And I know most CCRCs, you know, it's not like you have separate tins for IL, AL, and SNF. So, but we'll get some clarification and see where they land on that. Obviously, there'll be positives and negatives to that answer. And I think I mentioned this, but I don't know, I talk about this so much. So when we get to the end of a particular reporting, if you get to that circumstance where you're not able to use all of the provider relief received during that time frame, the balance does have to go back, and you have 30 days for the first reporting period from that September 30th date. So by October 30th, you would have to return any any unused funds at that point. So they are requiring folks to, the order of entry, data entry requires you to put your COVID expenses in first and your lost revenue second. I asked the question of whether you had to report COVID expenses. You know, I always go back to the fact that the terms and conditions say that you can use the provider relief funds for COVID expenses or lost revenues, not only use it for lost revenues if you didn't use it up with expenses. That was not how the terms and conditions went. So HHS said, you know, conceivably you could report no expenses. That's possible. The CLA folks feel like that raises a red flag. I think it probably depends on the circumstances. Certainly, if you are going to opt to not report any of your COVID expenses and just use your dollars for lost revenue, then you need to keep that in mind, that that will potentially impact that future reporting as well, because these periods of availability overlap and add on to each other. So it's not like you could go, it would be, I think it would be questionable if you went into the next reporting period and now started reporting COVID expenses that you could have reported in the first period. Then they might start asking questions, but I don't know. Part of me feels like the whole point of this is you should be able to use the funds the way you needed to use them. And so if you want to just use them for lost revenues, you should be able to do that. However, there are also going to be circumstances where folks got other assistance for coronavirus that covered so many of their expenses that really they're going to have zero expenses to report that have been unreimbursed or are not obligated to be reimbursed by another source. So there will be folks that will report zero in that expense category, even though they had expenses for PPE and for testing and staffing costs. So it's one of those, you know, work it through with your accountants and auditors. They're probably going to take a more conservative approach than I do, but the HHS has said you are allowed to report zero expenses and just report your lost revenues if that's what you choose. And I know some states are evaluating that because they have a cost-based reimbursement system and they're trying to figure out, you know, they have to use everything, all other assistance received first, but the cost-based reimbursement system, any expenses, you know, that they report then bump up their rates for future years. So that's where they're trying to figure out how to maximize things. At the end of the day, they just don't want you double dipping.
What, this is Bill Ginter from Mary Wade. What is the begin measurement point on the infection control costs?
So I need to double check my chart because there's so many dates. So this next reporting period will be January 1st. I'm trying to, is this my right document? Here we go. January 1st through March 31st of 2022 is when you're going to start reporting on the nursing home infection control distribution that you received at the end of August. For some people that got paper checks, that was early September. And it will also capture the September incentive payments that were received in 2 payments in November on the 2nd and the 30th, and the October nursing home incentive payment that was distributed on December 9th. So that will be in the second reporting period. And at that point, there is a separate tab or a separate section that you'll be prompted to report on those infection control expenses in the portal.
And the measurement period for those costs is the calendar year of 2020?
So the period of availability where you use those funds will be January 1st of 2020 through December 31st of 2021.
Okay, thank you.
Mm-hmm. Well, and I know there's a lot of folks that even if you got phase 2 and phase 3 really only based on what you had to submit to or to apply for those funds, it really was only designed to cover lost revenues and expenses from the first half of 2020. So the fact that we can continue to use funds for an extended period of time as a benefit, I guess on that front, I should have noted up front, we're still waiting for them to release phase 4. I can't remember if it was OMB or GAO just came out with a report basically noting that HHS hasn't updated their plan for spending the remaining provider relief funds since October of last year. And we have been arguing, I thought we would be able to get a phase 4 out by December of last year, and we are still waiting for that. Katie just recently sent another letter. We've talked to them directly, but sent another letter to the head of HRSA and said, you need to release these funds now because it's become urgent for folks. So the reality is the provider relief, there are some remaining dollars there. There should be another phase. They keep promising us it's going to be out as soon as possible. But I was told, at the beginning of June that it shouldn't take 2 months to get that out. And here we are 2 months waiting to get that out, that next round. And we know that it takes, usually the application process is open for 30 to 60 days, and then they start distributing stuff. So it could be a while yet. But we've been fighting for that. And we've also had to fight back because Congress, as they've been debating the infrastructure and the reconciliation kind of package, started looking at what they call unspent COVID funds. And since there was a chunk of change sitting in the provider relief account, we had to very sternly point out that it's not because it's not needed, it's because HRSA hasn't given us an opportunity to apply for it. So hopefully, that pushback on Congress, plus noting that more publicly to HRSA again, will maybe convince them that they have to open the floodgates on that one.
So I really haven't studied these PRF forms that much yet, but I'm wondering if there is a strategy to not reporting the infection control costs in the regular COVID PRF section because you're holding those funds to be measured in the other measurement.
I had thought about that too, and I think, at least if it were me, what I would be doing is looking at all the expenses that I thought I could tie to COVID, bucket the ones into infection control, see if I'm using up all of my money in this first reporting period, and then, report them going forward tied to the nursing home infection control dollars, because that was my thought process too, is want to make sure that I'm maximizing my use of these funds.
Right. Okay.
I'm thinking the same way you are.
Okay. All right. Thank you.
Mm-hmm. Anything else come to mind for folks?
Hi, this is Carol from McLean. And my question isn't about provider relief. I was just curious if you're hearing anything about the 3-day stay waivers. And is that something that will continue past COVID?
It's a good question. So the 3-day stay waiver is under they call them 1135 waivers, or that one actually might be a 1218. Anyway, they are tied to the public health emergency, but HHS or CMS can decide to end them prior to the public health emergency ending. So they can decide at any time that they don't think it's needed anymore and kind of retract that waiver. We have not heard any steps towards that. And I think with the uptick in cases related to the Delta variant, and there are certain parts of the country where we're seeing hospitals getting filled up again, that I would think that we won't see the 3-day stay waiver be revoked anytime soon. But it's always something that we're keeping an eye on. As far as extending it beyond the public health emergency and beyond COVID, I'm a big proponent of that. I know we are a big proponent of that, but I think what needs to be done is we have the benefit now of seeing what happens when the waiver is off, and it's off for everybody. So it's not just off under ACOs, it's not just off under Medicare Advantage plans. but this is like a massive mandatory demo that we're in under COVID. So we have the data now that says, you know, did costs go up dramatically by using the 3-day stay waiver? And I think it's an opportunity to find out if it really would cost the system more if we just removed that requirement. But having said that, I know when they were looking at the data for PDPM, we weren't confident that they had it kind of, that the data that they were reporting was accurate. Because you'll recall that it was really hard to get tests in the beginning and to test people. And we didn't always know if somebody actually had COVID. We were sort of guessing. So there are still some problems with the data. I think it is an opportunity though to kind of ask for that. We're still pushing for like observation stays to be included, you know, to kind of get around where some of the trouble points are. But I feel like there may be another opportunity to kind of work around that, because as we've been having conversations with the Center for Medicare and Medicaid Innovation around some alternative payment model options that our providers could lead and participate, you know, take a more meaningful role in, we have talked about the idea of, could we have direct admits from the community, just with like a physician's order sort of thing, where somebody needs stabilizing and they don't really need to be in the hospital. They're not going to get better. They have a chronic condition, but could we stabilize them in a place where they'd have 24/7 kind of supervision and oversight? And they seem to find that kind of attractive. So that might be another way forward where we get beyond the 3-day stay and we start, you know, approaching care delivery a little bit differently. So sorry, long answer, but there's a lot of things in play.
Yeah, I mean, it's still in effect. I know some
Yes.
of the hospitals have been pushing back on it, but it is still in effect for everyone. And I had a discussion with some other groups a couple days ago in the state, and you know, the Medicaid directors may be increasing their push to have this change and permanent, as well as I think you might see the consumer groups. I mean, once this is taken away from the consumers, I think, you know, if they pull it back, I think you'll get the AARPs, the Center for Medicare Advocacy and others saying, wait a minute, you know, they've got a taste of it now. And I think so they'll be on our side now and trying to help to get rid of it, the 1965 rule, right?
Yeah, that would be great. I don't even understand why we still are having this conversation. It seems to me that, you know, the physician at the hospital is making a determination where this person needs to be served, whether they had 3 days or not, or a doc says, you know, you need this level of care. It's not us, like, you know, like ambulance shopping or something.
Right. And who stays for 3 days? You know, it's making artificial hospital stays. So
Well, I would argue it costs more to have than not to have in the long run.
Well, yeah, you think about even 3 days in a hospital, what does that cost versus are we capable, you know? And I suspect some of our nursing home members would say that they're not staffed up to deal with certain level of patient or person. But, you know, it feels like this is directionally where we're headed.
yeah, and it would also be interesting to see what the deterioration in the condition of spending 3 days in the hospital. You know, maybe they're having a better rehab coming out sooner and getting into rehab as opposed to sitting in a hospital bed for 3 days. So there's that argument also. It'd be interesting to see.
Well, you think about it, you know, somebody has a hip replacement now and they get you out of bed like within hours. They don't want you sitting for very long. So.
Well, Nicole, I can't thank you enough for being here.
Thank you.
I don't know if we had sort of a proper introduction of you, but this is Nicole Fallon from LeadingAge National, who's come on to, you know, help us all sort of understand and interpret the provider relief on the federal level. So, and she, you know, has made herself available whenever we need her. So if at any other point you wanted to bring us back to this monthly call, she'd be happy to join us. And she's also available to you as members if you need to contact her. So happy to bring this national resource to you. Hopefully you were all on the call yesterday, if those of you who are on the Medicaid program, for the information on the Medicaid nursing home increases, and we're waiting for the FAQ number 2 to come out. And if you need other questions answered on the FAQ number 2, let me know. I know we're scheduled to end in about 5 minutes, but if anyone had any questions on that program that I might be able to help you with at this point. Hopefully the call yesterday didn't confuse you more.
Just one clarification on that, Mag, related to July 1st versus sometime in July. You know, does it have to start as of 7/1 or could it be the last week in July?
We asked that specifically before the call. It does not have to be specifically July 1st, but it has to be before July 31st or before, but not before July 1st. So somewhere between the July 1st and July 31st, it has to be implemented. And if you have to go retroactively to implement it, they're asking you to do it as soon as possible, August, September, not to wait way out.
The one thing, can you hear me?
Yeah, I can hear you, John.
The one thing that I think we really need to push for, when they were talking about when you got to some point near the end and you had a sum of money to use up, that you would be able to give bonuses or additional increases or whatever to satisfy that. Because this particular calculation is exactly that, just a leap of faith. We have no idea what we're going to have for Medicaid days over the next 12 months.
Right. And, you know, we brought that up to her, to DSS prior to the call. And she had said they understood that there would be reasonableness. So hopefully they'll be able to respond to that in the FAQ number 2. But they got the fact that, you know, you just don't know from now till June what your census is going to be, what your Medicaid census is going to be, what the building next to you is going to do. That's why I brought up to her, you know, if the building next to you decides to close or reduce their beds, suddenly your census is going to bump. You can't predict that. So they understand that. So hopefully they'll reflect that in the FAQ.
Yeah, what situation that we're in is because of staffing, we have actually limited our census. We're limiting it to about 20 less than we actually can take because of staff. So what that census is going to be between now and the next 12 months, who knows?
Gotcha. The other thing is
We actually had to do this. Oops, sorry.
Oh, sorry. Go ahead, Lori.
We've had to do the same thing. We've had to limit our admissions because we don't have the staffing. It's awful.
Yeah,
The other thing I'm pretty sure, I wish she had just responded to it. You do not have to give an equal amount to every person in the building. You know, someone asked that question, she kind of hesitated. If you wanted to just give the CNAs an increase with all the money, you can do that. If you wanted to give some people a 2% or a 4%, I am 99.9% sure that will be allowed. And I hope they'll make that clear in the FAQ number 2.
As long as you spend the money. Right?
As long as you spend the money, right?
Yeah, she did hesitate on that.
I think it caught her off guard. I don't think anyone had asked her that before. And so I think she just didn't feel comfortable responding, but I think that Matt and my response was pretty strong as the, oh, no.
Yes, it was.
You know, so hopefully that'll.
Any idea when the second FAQs are coming out?
I kind of expected them to be today or tomorrow. We have a scheduled call with them tomorrow at 9, so I'll know for sure when they're coming out. But you know, the problem is they can't just send them out. They have to have everything reviewed by OPM, and that kind of holds things up. So we're going to check on that, though.
Thank you for coordinating that yesterday.
No problem. Jukes, did you have a question?
So also what I thought was a little confusing yesterday was that a portion about, was she also recommending that that next year's 4.5% needs to be given in a time period of only
Yes.
July?
Mm-hmm.
Like why? I guess I don't understand why that.
Because they want it to be reflective of, and you know, some people wanted to give it all right now. But they want it to be reflective of the increase, the 4.5 increase that comes July 1st. And then they don't want it to be given, they want it to be responded to right away. It's really, and I think it's a political thing. You know, they're providing this rate increase to give the employees a raise, and they want it to be reflective. We gave this rate increase on this date, and we want it to be reflective. And so, plus in July, we're not going to know really what the impact's going to be, because you're going to have a new rate, right? We're going to go to the acuity rates. So that's all going to be in flux. So we'll see as we get closer to July what the rules will be. But you'll start knowing in October what the effect of the acuity rate system will start to be on your rate system. But July is kind of a different game, because we're going to have the acuity rate system. So as we get closer, we'll see what the actual rules will be. But I think right now you should think and plan for giving it within July.
It just, yeah, I mean, every organization's different. Everyone has annual review processes, you know, annual valuations. So to say that that doesn't apply, like, you know, even in a year's time, it just seems really, really, I don't know. I don't even know what to say. Like how it's effectively like controlling how we operate in a sense. And
I know, and we pushed back on that all session, and it just, somebody else was pushing in a different way. And so.
thank you.
Why did she get?
All right, so when's our next meeting, Andrea?
Yeah, that's the insurance.
Our next meeting is going to be September 23rd at 9.
All right, terrific. Well, thank you, everybody. Really appreciate your time today. And Nicole, thank you again. Can't thank you.
Thank you, Nicole.
Good to see you.
Thanks, guys. Thanks
Thank
for
you so
listening.
much.
Bye-bye.
Bye-bye.
Bye.